Next, we will hear from Anita Glicken, Professor and Associate Dean Emerita at the University of Colorado, Anschutz Medical Center. She was a founding member of the National Interprofessional Initiative on Oral Health and now serves as Executive Director. She brings over 30 years of research and education experience to this conversation, and we're so grateful she can be with us today to share her expertise and perspectives.
Thank you, Catherine. I appreciate that introduction. 12 years after NIOH was founded, we continue to play an essential role in a national effort to create systemic change by bridging historical, medical, and dental silos. We began as a partnership between three foundations, a philanthropic venture that created a case study in collective impact, engaging non-traditional partners to integrate oral health to activate change. Capitalizing on two emerging trends, interprofessional core competencies for collaborative practice and payment and practice reform designed to achieve the triple aim, we considered how oral health, given its critical relationship to overall health, could be the perfect exemplar for interprofessional education and integrated collaborative practice models to improve health equity and reduce disparities. Our assumption was that workforce transformation is critical to accelerating change, and that patients would have better oral health if their primary care provider addressed some oral health needs during routine visits, including education, preventive care, and referrals. Next slide. So how did we get here? In the US, as you've heard, patient care is typically fragmented. Many of our patients see a physician regularly who don't visit a dentist. And this doesn't include PAs, nurses, and others who provide primary care. What this slide does document is 108 million missed opportunities for primary healthcare providers to engage patients in preventive oral health care, education, screening, for early identification of disease and referral to dental professionals. But fragmentation of care doesn't just impact a provider's communication to the patient. It also impacts the flow of information between providers related to their patient's oral health. Next slide. We know that there is a bidirectional relationship between oral health and systemic disease. However, as depicted on this slide, typically there's little to no communication between our dental and medical care practitioner silos. The flow of information about the diagnosis and treatment of a chronic disease like diabetes, for example, is heavily reliant on the patient acting as conduit, which is not only a serious burden on the patient, but also often an unreliable means of communicating critical health information. Next slide. Given these issues, we now recognize that in addition to fragmentation of care, basic access to dental care remains a significant barrier, with 62 million individuals living in health profession shortage areas and 2/3 of Medicare recipients lacking dental coverage. So where do they go? As you've heard, they end up in what I call the rabbit hole of our nation's emergency rooms, where providers are often unprepared to deal with their concerns. This issue of insufficient dental health professionals to care for our population won't be resolved soon. So we needed as a country to consider who else we could engage in prevention, because unlike many aspects of normal aging, poor oral health can be prevented. Next slide. In 2009, to address these systemic problems, NIOH evolved as a consortium of funders, health professionals, and national organizations with a shared goal of eradicating dental disease. Our assumption was that if we could integrate oral health into the education and professional coursework of providers, they would enter the workforce ready and willing to partner with other health professionals to create a new standard of oral health in primary care. We recognized that primary care prevention is critical, but providers also need to be ready to screen for oral health concerns in acute, chronic, and specialty care. The NIOH is a systems change initiative, and we provide backbone support and facilitate interprofessional agreement and alignment across health professions to ready an interprofessional workforce for whole person care. We work across medicine, PAs, nursing, dentistry, pharmacy, and social work. Next slide. Now, oral health isn't a new concept, and this graphic captures the opportunity for change. We see the progression of the field and the growth of policy documents that over the past 20 years have been driving change across our healthcare system. Two of these documents have given a big lift to the oral health integration movement. HRSA's report on the integration of oral health and primary care practice describes the what we can do by defining a set of oral health core clinical competencies for non-dental providers. The Interprofessional Education's Collaboratives Core Competencies for Practice describes the how we'll work together in a collaborative, team-based environment. Next slide. Change happened because we intentionally adopted three core strategies. We cultivated leaders, facilitated interprofessional learning and agreement, and we create and support tools and resources to build a shared understanding, knowledge, and skills in oral health. These strategies inspire a philosophy of collective impact, where we work across health professions in mutually supportive ways to create a movement that drives change, leveraging the unique capacities of each partner to maximize our impact. Next slide. So I want to shift our attention, as I know you're interested, in the tools and resources that are preparing our primary care workforce and others to integrate oral health. The exponential growth of Smiles for Life, the nation's most comprehensive and widely used oral health curriculum, now has over 3 million unique site visits and 470,000 courses completed for credit. However, anyone can use Smiles for Life without registering, and because educators can download modules, slides, and lecture notes, our numbers only recognize a percentage of those actually using the curriculum. The endorsement of 8 health professions and over 20 professional organizations documents the widespread acceptance of the curriculum across health professions, as well as a growing interprofessional agreement on the need for shared ownership of oral health. The endorsement of 8 health professions is supported also by the 8 independent modules that extend across the lifespan. The modules log and track progress through a back-end database, making it possible for many of these professionals to receive up to 8 hours of continuing education, free continuing education. And because it's profession neutral, these modules can be used by health centers and other facilities to educate all staff in a common curriculum, including specific instruction in team-based interprofessional care. A new series of modules were recently adopted for community and frontline health workers, including a focus on the needs of pregnant women and older adults. Next slide, please. While the Smiles for Life database tracks the spread of the curriculum, it doesn't help us understand how the curriculum might be impacting patient or practice outcomes. In a recent survey, we asked users of Smiles for Life if it had influenced their activities by leading them to start an activity, perform it more regularly, or perform it better. Providers across professions reported to us that Smiles for Life influenced many oral health activities, but especially those that required more oral health knowledge. And I'd like to drill down on these. Next slide. Referrals are something we'd routinely expect a direct care provider to do. Yet even with that, we see that 1/3 appeared to do this more regularly, and almost 40% felt they did this better. In terms of anticipatory guidance, 60% said they felt they did this better, and almost 50% said they began applying fluoride varnish as a result of the curriculum. Next slide. Almost 60% stated they do a better job of caries risk assessment, with about the same number conducting a better oral exam, with 50% feeling they do a better job of oral cancer screening. In summary, we found that the curriculum appears to positively influence the practice of oral health across professions. We also learned, however, that organizational factors may influence the uptake of oral health activities in primary care practice. We're often faced with significant challenges when it comes time to integrate oral health in practice due to the systemic ways that practice is organized. Next slide, please. So I briefly want to mention our work with Qualis Health to create a white paper and oral health integration framework that supports these practice transformations. The framework describes 5 actions that primary care teams can take to promote and protect patient oral health. Ask about risk factors and symptoms. Look for signs of oral health risk or active disease. Decide on the most appropriate response. Act to offer preventive interventions and referral for treatment. Document through structured data to support shared decision-making and population management. Qualis Health also released an implementation guide, a toolkit reflecting our experience field testing 19 diverse primary care practices that used the framework. The tool and the guide includes specific resources that practices found helpful, like referral agreements, patient engagement strategies, and EHR templates. The tool allows settings to customize integration efforts based on the setting, staffing, and patient population. Because we know that while policies and rules that govern our healthcare system are often national, our solutions must be local, responsive to these communities and populations that we serve, so that all patients can have care whenever and wherever they need it. These tools are just 2 of the many examples that can be used to support oral health integration at the local level in education and practice, while at the same time pushing and transforming systemic levers for interprofessional practice and oral health integration. Next slide. In addition to tools and resources, we've intentionally invested in cultivating leaders. In the PA and nursing professions, this has resulted in systemic change, integrating oral health into education and practice for those professionals. National studies now document that 96% of reporting PA programs now integrate oral health, and their graduates are 3 times more likely to integrate these skills in practice. ONEP, our nursing arm, has created resources and strategies for our nation's 4.2 million nurses who are seeding transformation across primary, acute, and chronic care settings. Next slide. Our most recent strategy is to support, align, and connect partner efforts. NIOH is a recognized thought leader for public and private policy organizations, payers, and health systems. By way of example, our recent partnership with the Primary Care Collaborative resulted in their publication highlighting the scope of today's integration efforts across the U.S. It's a great resource for those seeking examples of interprofessional initiatives that highlight collaboration between primary care and dental providers, including dental therapy. Next slide. The disruption that we're witnessing today, while challenging, provides a unique opportunity to think differently about the way we work together. Collective impact has been foundational to accelerating change and to align a growing interprofessional oral health field. But change is never easy, especially when we don't have a shared concept of where we want to end up. So in this defining moment, integration is critical to our work, potentially transforming the way much of today's care could be delivered. The bidirectional relationship between oral and other systemic diseases provides a strong rationale for integrating oral health and primary care. However, payers, policymakers, and clinicians often use the terms collaboration, co-location, and integration interchangeably and inconsistently to describe these varied approaches to practice. Depending on the needs of specific communities, we know that all of these models have value. But while we work to create a shared understanding of the terms to characterize the things that are taking place in practice, we're also exploring whether benchmarking degrees of collaboration can help us identify next steps or best practices to prepare our workforce and health systems for the backlog of future care that we face from the pandemic. We advance a vision of transformed integrated practice, where providers and patients view the operation as a single health system, treating the whole person using shared decision-making, EHRs, and payment systems. An equitable system where principles of prevention and whole person care are applied to all patients, not only targeted groups. Next slide. So what have we learned? We've learned the organizational change process requires system-wide intervention, that having the right people in the right place for the right reason can change ideas and practice. And the key is having the right tools and resources to really have an impact on the knowledge, skills, and attitudes of our providers. We can't achieve our vision of oral health for all unless we change our approach to oral health care. Integration and collaboration is key. We can't do this alone. We really need to move beyond the symptoms of health disparities to aiming our policies and funding at changing the structure that creates those disparities. NIH activities are made possible due to the generous gifts of our legacy funders. We appreciate that along with us, they're making the right thing to do, the easy thing to do. Thank you for the opportunity to speak today.
Thank you, Anita, for sharing how we can work together across the health professions to improve oral health and reduce disparities.